Okay, so today we're going to talk about the anion gap and why it's important in DKA. So first, let's get a little bit into metabolic acidosis. So the reason why we follow an anion gap in general is because we want to find out why someone has a metabolic acidosis. Now, DKA is one of the reasons why you would get a metabolic acidosis. So, let's talk about what an anion gap is. So, an anion gap is the difference between your cation and your anions. What do I mean by that? The principal cation, which is positively charged in the body, is sodium. Now, your principal anions, which are negatively charged, are your bicarbonate and your chloride. So pay very close attention to this. The difference between the two, between your cations and your anions, is your anion gap. Now, an anion gap is 100% normal. You're supposed to have a gap because if you have more negatively charged anions, you're gonna have a gap because there's gonna be more negative than there are positive. So with that said, let's move on. Now we're gonna get into how does this apply to DKA. Let's say you have a patient that comes to the hospital and they have an anion gap of 25. Normal anion gap is 12 plus or minus 4. So if you have somebody that comes into the hospital with an anion gap of 25, that's pretty high. Now you gotta ask yourself, what are some reasons that will cause somebody to have that gap widen? What negatively charged anion is contributing to this gap, causing it to be widened? So, just a quick rule of thumb with DKA. If you have a patient that has a history of diabetes, they come in with a blood sugar of, let's say the blood sugar is about 600. Blood sugar 600, you do a beta hydroxy, which is positive. So beta hydroxy will tell you that there are ketones in the blood, okay? Which means that the body has moved from which means that the body is now using fat for energy, okay? So you have a positive beta hydroxy. Then you also have ketones in your urine, right? And then now you notice the patient has a gap of, let's say, we said 25. So whenever you have a metabolic acidosis, right, you're gonna have this anion gap. So you have to ask yourself, what negatively charged anion is contributing to this gap, causing it to widen? So you do the whole workup and you find out that this patient has DKA. Now, the treatment is you put the patient on insulin, you're checking BMPs every 4 hours because you want to check the potassium and you want to see if that gap is closing. So what happens a lot is that sometimes the nurses will say, oh, well, the blood sugar is normal. Like, why can't we just shut off the insulin drip? The DKA is resolved. So the question is, how do you really know that the DKA is resolved? How do you know that? The only way to truly know that is by accounting for that close in that anion gap. Now you do have some situations where, let's say if this patient is a cirrhotic and they have let's say this patient is a cirrhotic and they have low albumin levels. Albumin can throw off the anion gap because of its ability to bind and release hydrogen ions, right? So you have to take into account what the albumin level is when it's below 4. So if it's below 4, then there's a calculation that you can use that'll help you to determine what the anion gap really is. So once you calculate the anion gap in retrospect to what the albumin levels are, that's your true anion gap. Now, you could have a normal blood sugar. Let's say someone comes in with a blood sugar of 600, right? You've given them fluids, they're on an insulin drip, now their blood sugar is 190. How do you really determine that that DKA is resolved? And it has nothing to do with the blood sugar. I just want you to know. You can have a normal blood sugar and still have ketoacidosis. So what you're supposed to do is you're supposed to monitor the anion gap. When that gap closes, that tells you that now that ketoacidosis has resolved. So the reason why we add dextrose to the IV fluids is because we want to make sure that the patient doesn't become hypoglycemic in the process of us trying to resolve that DKA. So the insulin is doing its job, the patient's getting fluids, and now the patient is improving. But that DKA, that ketoacidosis is still there, okay? So, key is you have two closed gaps, right? In the hospital, we usually like to have a serum bicarb more than 18 and a anion gap. In the hospital, we usually like to have an anion gap that's around at less than 15, because 16 is right on the cusp of almost being open, right? The gap being open. So you're at 12, 13, pretty much the gap is closed, and you wanna wait until you get two of these before you decide to say that the gap is closed and the ketoacidosis has resolved. Now, if you prematurely just say, oh, I got a blood sugar of 150 and the patient is no longer hyperglycemic, but that anion gap is 20, what's gonna happen is you're gonna get that rebound hyperglycemia and the patient's gonna go right back into a full-blown DKA. The key really is monitoring that anion gap. This is why anion gap is so important. Now, there's going to be lots of reasons why patients come in with a metabolic acidosis. I'm just going to say this before I close. So the reason why sometimes patients come in with a metabolic acidosis, it could be three reasons. The first one being increased acid formation, right? And in this situation, this is DKA, ketoacidosis, increased acid formation. So this increased acid formation is what is responsible for your high anion gap. They call that, you want to get technical and you want to get, sound like you're smart, you're going to say HAGMA, okay? High anion gap metabolic acidosis, okay? You're going to put on your paper, oh, my patient has HAGMA, okay? That's what you do. Anyway, so that's a reason. The second reason is severe loss of bicarbonate from diarrhea, right? So if you have a lot of loss of bicarbonate when you have severe diarrhea, and usually that's non-gap. That's another video. Third reason you would have a metabolic acidosis could be due to decreased renal excretion. And that could be from something called RTA. Now, I'm not gonna get too much into that because I'm losing sight of the purpose of this video. That will be for another video. Anyway, I hope I was able to help you to really understand, because I'm big on understanding. I'm not big on memorizing. In nursing school, I did a lot of memorizing. And when I became a nurse practitioner, I realized that in order for you to really, really understand, you cannot memorize, you have to understand the concept. So I started changing my study habits when I was towards the end of nursing school and becoming a nurse practitioner. My studying was completely different. So hence the reason my teaching style is different. I'm different. I'm not your average clinical professor. I'm not your average nurse practitioner. And that could just be because I'm not average. Anywho, I hope that my message came across in this video and you understand everything clearly about what I was trying to explain to you. So, please, please subscribe to my channel, push that red button, because you know you're gonna learn a lot from me. I got a lot going on in my brain that I want to share, and I know that you will enjoy my channel just as much as I do. Thank you for watching. Stay tuned for more videos. Bye.